Emma, we can start.
All right. Hello, everyone. I warmly welcome you on behalf of IASNM live webinar series. This session will have a 45-minute presentation, and this will be followed by 15 minutes of Q&A session. You may submit your questions via the chat box throughout the session, and we will address the questions in the order that they are received. It is now my absolute pleasure to introduce Dr. Shahein Tajmir. Dr. Tajmir is a dual board certified radiologist and nuclear medicine physician with subspecialty training in abdominal, musculoskeletal, and cardiac imaging. Dr. Tajmir is currently the clinical director of PETMR at Emory University in Atlanta, Georgia. He has an interest in IT and operations, as well as practice development, and having served as the chief resident representative during both EMR and PACS migrations at Mass General Hospital in Boston. He is the moonlighting coordinator managing 60 moonlighters across 5 sites and on the revenue recovery task force when trying to reverse systemic causes for billing denials. Dr. Tajmir.
Hi, thank you for the introduction, Saima. So I am one of the faculty at Emory. Thank you to the IASNM for inviting me. Today, we're going to be talking about PETMR the first year. So Emory recently got a PETMR. It was installed some time ago during COVID. And then we first started using it clinically about 1 year ago. So this is a kind of an introductory lecture on kind of things that we've learned and how my philosophy of using the machine is, which is a bit different from other places. So today's talk is going to be talking about what is in a PETMR and what am I putting in my PETMR exams. A little bit of MR basics, just very, very basic. Then some of our interpretation of reporting workflow, a few interesting cases, and then I actually have on another workstation next to me some demo exams that have been anonymized, and then MIM, so we can show it. Loading these is a little bit tricky, but once it happens, it's not so bad. And then we'll have time for questions. So the first thing is, what is in a PETMR? So the PETMR that we have is a GE machine. There are basically 3 machines that exist in the US. There's the Philips, which no one buys, the Siemens, which early adopters bought, and then the GE. So the GE is based on the GE Sigma MR platform. It has all the MR sequences that a standard diagnostic MR can do. And unlike a sequential PET-CT, PET-MR is simultaneous. So why are we doing these? Why would anyone do these? You can combine the soft tissue contrast of MR with a very, very high quality PET. And it actually, the sum of the two is more than the individual components. It's actually easier to interpret both sides once you have them fused, and it gives you much more diagnostic confidence. You can also save time and combine exams. So if a patient needs to be getting an MR for whatever reason and a PET for whatever reason, you can get them in one exam. You can do this for intended things where, say, like there's liver problems and you want to focus on the liver, but then also do the whole body restaging. You can also do it in the reverse where, like, okay, the patient is getting a lymphoma restaging and they also need to have their CNS cleared. So you can do a brain MR with a whole body PET as well and kind of clear both in one exam. You can answer really complex questions because a lot of times people get imaged sequentially, or they're imaged, well, first they do a CT, then they do a PET-CT, then they do an MR, and all of these things are different points in time, and the patient moves differently, and there's not fusion, so it's always kind of this hedging. So you're able to really answer these tough questions, recurrence versus residual disease versus something else, with this really high quality imaging. We first started doing scans about 11 months ago on November 2nd. And since then we've done quite a few. I think we're probably more than 110, maybe 120 at this point. We only have the machine 3 days a week, so the rest of the time is for research. So we're actually using it a decent amount. What are the uses that we've been finding? So unlike most places that have PETMRs, we have not done much neuro. We are mostly body and cancer. So we're doing it for local therapy planning and response. Our interventional radiologists love it for Y90 for initial planning as well as for response assessment. Same thing for any other local therapy that's IR driven, so ablations or bland embolization even. The radiation oncologists are very interested for planning their EBRT and brachytherapy off of the pre-treatment scans as well as for response assessment. The surgeons are using it quite a bit to say there's one lesion in the liver, we want to make sure there's nothing anywhere else before they go take them for a partial hepatectomy. or any other things, similar places. If they really want to know to exclude something somewhere else or include, just if they want to make sure, that's helpful for planning. We kind of talked about problem solving when conventional imaging is indeterminate. We have done a small amount of seizure focused localization. That has been some kind of strange logistical issues to finally get that started, but we are doing it. And then other places, not quite us, but although we are building this protocol right now, is working on cardiac indications, which would, at the beginning will probably be for sarcoid viability and possibly infection. So my philosophy and kind of how PETMR has been deployed since approval in 2014 has been, are slightly at odds. So in 2014, GE got FDA clearance for this machine, and then their educational materials, what the apps people come when they come to your site, what they basically tell you to do is to make your protocols so that you swap out the CT of a PET CT with an MR. And that's it. Maybe they throw in a post-contrast sequence or pre-contrast sequence, maybe a little bit of a T2 here and there, maybe a diffusion, but they don't really give you any guidance on how to use the machine, because in their minds, it's just swapping out the PET CT with the PETMR. In fact, that's how their software is built. And I think that's a huge failure of imagination, and because it's not using the machine for what it can do. And that has led me to build kind of more difficult to execute, but have managed to do it, protocols that really show off what the machine can do. So these images here are kind of just what you sort of get if you go with the bare bones GE model. So you get an MRAC sequence. These are MR attenuation, which uses a T1 GRE, kind of low res, very fast Dixon sequence, which does in and out of phase imaging, which then can decompose into water and fat pixels. These all get fed into the MR attenuation correction sequence, which then generates density maps. This is the raw PET. This is the density map that it's generated from these sequences over here. And then this is now the corrected PET, and then this is it fused. So that's kind of the basic, MRAC to PET, attenuation system of the PETMR. So what I have decided to do is take it from, okay, this is what GE says to do. Okay, let's do a whole body PET, maybe some contrast, use our MRACs, just, swap out the PET CT, but then also throw in a full diagnostic MR of the region of interest and a simultaneous long list mode acquisition PET. So it gets really old saying long list mode acquisition PET over and over and over again. So I usually just say super PET. And now you're able to get both of these exams in one exam, one slot. Our total exam times, it fits, and the patients are able to make it through it. So when you have this kind of information, you have this way better PET, you have way better fusion because they're required at the same time. And you also have the whole body staging at the same time. So there's a lot of interesting things that can be done with this that is better than just only using the PETMR to churn out images like this. So here's some examples. And at first people were very skeptical, including my division chief, about the value of this. So on the left is a whole body image acquired, and the PETMR has conventional PET beds. Each PET bed is 24 centimeters in Z dimension. So this is a copper 64 dotatate using a Q-clear reconstruction, which is a resolution recovery or a Bayesian probability reconstruction, but it's basically kind of required for the magnet. And this is a 4 minutes per bed. Pretty good imaging. It's not terrible. It's actually quite good, but then you can make it better. So one of the things that you can do is acquire for longer, right? So when we're doing liver MR, it takes about 18 to 20 minutes to acquire. If you acquire that whole time, you get a much more crisp image. You can also apply respiratory gating, which is Q-static. And so then you get also loss of the blur in the Z dimension of all these metastases here. And because you also have that respiratory compensation, your fusions look better and you have the diagnostic images. So there you do get more information. You also find things that are missed because of blurring, because of patient habitus, because it's center of the abdomen, it's hard to see. So you notice here, there's a metastasis here. That's actually residual disease of the pancreatic resection margin. This is also something here. These were kind of would have been written off as noise had you not had the higher resolution images. So this super PET is a longer acquisition. It's paired simultaneous to the diagnostic MR. A lot of the benefit is the longer counts because you have to spend the time there anyway acquiring the MR, so you might as well acquire the PET at the same time. because you have so much counts, you can then do more fancy things. So the resolution recovery methods, which is the Q-clear, the respiratory compensation on the GE, not that I'm advertising the GE, but it's just how it works, is it operates only, it does not use the bellows or anything, supposedly. This is sort of not true, but whatever. It operates in image space. So it uses the quiescent phase of respiration. And then if the patient is breathing too much, it will then delete the data that is not in the quiescent phase of respiration. And then you get less counts, but you get no motion, which is much better. And again, this is simultaneous with MR, which helps a lot with fusion. So we kind of go through these various steps as you apply them to the super PETs. So the top is the raw PET. It's good, but it could be better. You still see the z-axis blurring from patient respiration. It's not as crisp. This is where the Q-clear really comes in. It definitely helps sharpen the image, make things a lot better. And then the Q-static is where the patient respiratory compensation happens. So you can see, just comparing Q-static alone versus the raw PET, you have less z-axis blur, right? Because the patient, all that extra data has been deleted. So it is a little bit noisier of an image, but you lose the blurring as you get better fusion and you know where things are. It also helps sharpen up things. So this patient had a distal pancreatic tail neuroendocrine tumor, which was resected and then had metastases, and they wanted to know, is it all only liver disease? So that they should then treat that, you know, locally, or did she have distant disease and go for PRRT? That was the point of this exam. And so you can see again, like this pancreatic resection margin, you know, residual disease becomes much more obvious when you apply all the additional image optimizations and would possibly have just been ignored. So this is what the images come out as. So one thing that is different from PETMR from PET-CT is that a lot of your sequences embedded in their names have a lot more info. And as you're starting, you'll want to keep this so that you can get yourself familiarized with all the different types of reconstructions. And a lot of places, I think over time, we're starting to simplify, but I am trying to keep some of this stuff in because it helps when you're interpreting, like, oh, is this something that had Q-static applied? Is this something that had you know, Q-clear reconstruction applied, or is this a non-attenuation corrected, or is there some other things? Because sometimes you may find that there are weird artifacts that we haven't even fully characterized yet with these software processings. So the top, these are the whole body sequences that come out. So you get the regular AC, the QC 400 Q-clear reconstruction, and then the non-attenuation. And then on the super PET, we kind of get each of the combinations. So AC PET only, QC Q-clear only, Q-clear plus Q-static, Q-static, and then non-attenuation images. So here's, where is my, there we go. All right. So here's kind of how our protocols are. So protocol design is challenging, and it takes a lot of collaboration with whoever you're working with the MR physicists, with the respective abdominal or whatever diagnostic radiology division that's going to be looking at the MRs, because you got to be able to fit things into the times that patients can do, and then also that you get a diagnostic exam at the same time. So our liver, for example, is this is the protocol. It's the same for FDG, for any tracer that we would use with the liver. We do a whole body first, and for FDG, it's 2.5 minutes per bed. And then once we finish this, and as we're acquiring each bed, we do a T1, we do the MRAC, which is like a 20-second or 15-second sequence. We do a T1 FATSAT pre, which is also a fast sequence. It's a gradient lava type sequence. And then we also do a T2 single shot. These all acquire in less than 2.5 minutes. So actually the PET is the limiting factor here. Once we finish this, we then do a diagnostic liver MR with our liver list mode PET. It's around 18 to 20 minutes, sometimes a little faster, sometimes shorter. It just depends on how well the patient is at holding their breath. And then we go back, give contrast as part of this exam, and then do a whole body T1 post, which I think is my personal workhorse sequence when I'm interpreting the whole body. So that's how we get our exam. Same idea, but with dotatate. I believe this is with gallium. So our gallium uses 3.5 or 4 minutes, just kind of depends on BMI. Same idea, we do the whole body first, then we come back to the liver, then we do the whole body post. So that's kind of the model for doing a whole body and a region focus of exam in one session. The total time is around 40-ish, 38 to 40 minutes for this one. For this one, it's a little bit longer just because of the gallium requirements. So that's how it goes. For Axeman, which is rapidly becoming obsolete, but this was what we first started with. This is what we had. We didn't have PSMA at the beginning. This one's a little bit different. So we start at the bottom, and then we do variable bedtimes based upon areas of importance. So patient gets localized, everything is pre-processed on the scanner, they're lined up, PET beds are assigned, everything is set. We pull the patient out, inject them, set a timer. At 3.5 minutes, we start image acquisition because this machine takes a little bit of time to get started. And then by 4 minutes, we're starting to acquire. We do 3.5 minutes for each bed up until about the diaphragm, and then 2.5 minutes for the rest. Then we come back and do a prostate diagnostic MR. This simultaneous PET is honestly not that helpful with the AXNM because by distribution, it's long gone, but you're able to fuse this with the whole body and it actually works out pretty well. And then we come back, just because we do contrast here, we then come back and do our whole body post. However, now that we have PSMA, we've since inverted the protocol. And there's a reason for this. And the biggest reason is to do a trick with dual time point imaging. So what we're doing is we do a prostate diagnostic MR first. We get our prostate sequences, we get our list mode, and then we come back, do our whole body. And as part of our T1, since we don't have a T1 pre, we just take the T1 post, which is fine. And then we do either a T2 or a whole body diffusion. And we kind of go back and forth on an experimental basis, but we are imaging the whole body, and then we can then look at both sets of images. Similarly with the pelvis, we can do a similar thing. So we do a pelvis whole body, or a pelvis focus, then we come back and do the whole body post afterwards. But we're getting 2 PETs and 2 different types of MRs with each exam. And so just some example protocols that we have here. So our pelvis protocol, the ovarian, quote unquote, is straight to the body, no angulation. If there is an endometrial cancer, cervical cancer, rectal cancer, those all will have axial, oblique, angulated MRs, which add time to this because it takes time for the patients, for the techs to acquire these and for them to talk to the radiologist. But roughly these are within the 45 to 60 minute acquisition time. So we're still, it's a lot of scan time, but we're doing 2 exams at once. So patients, at first we thought more people would bail, but we're actually making people get through it. I think that is a credit more to our techs than anything. So that's a lot thrown at you, but that's kind of the sort of protocols that we're building, and it allows us to do really neat stuff. So for an exceptionally simplified comment on the MR sequences that we're using, we're going to talk about MR basics. So conceptually, this is how I think of MR, image acquisition, and how it works. And it works for people who don't have as much experience with MR. I have a lot of it, but I think this is how I explain it to trainees and also to non-MR focused radiologists. So, MR works at the proton level. And so when the protons in the body or any substance that wants to be imaged, they just kind of rotate their spins however they like. But when you apply a super, super strong magnetic field externally, either a 1.5T or a 3T, all of the spins want to orient relative to the field, and they want to point in the same direction. And so that's kind of what once you put the person in, their body orients, and then you apply RF pulses externally to perturb the spins, just kind of smack them out of the order, right? And then as you start doing that, they perturb. And then when you turn off the RF pulse, the spins return back to how they were. And they want to align back with the magnetic field that was applied. So when you do that, that change in spin releases information that the MR machine is able to read out or listen to. Literally, it's a sound. It's an RF pulse. And that allows us to do images, right? And so as you apply pulse, turn off the pulse, you have perturbed the protons. And then as you listen for the protons to return back how they were, you then are able to generate your image. It's a different world from nuclear medicine, but that's how it works. So this then leads to kind of my mental classification of types of MR sequences, right? So you can think of them very simplistically as a anatomy type sequence or just a structural type sequence, and then also a tissue characterization type sequence. So if you're thinking anatomy type, that's often the T1s, not always, but often. It depends on the pathology they're trying to figure out. Sometimes certain things T1 is better for characterizing than T2, but functionally, most of the time, the T1 is going to be your workhorse sequence for figuring out where things are. So when you're fusing your PETMRs, you often want to fuse to your T1s to see if, where things are. It's kind of your equivalent of your non-attenuation or attenuation corrections CTs. And then, you can do a T1 pre, a T1 post. This is a T1 gradient lava, fat suppressed. So, you see where things are. Now you see, like, here's the liver, you see lesions in the liver. Now, are they dead? Are they alive? Who knows, right? You need other things to figure that out. So that's where the T2 type sequences come out. So T2 sort of mostly images edema and fluid because that's how it's weighted. And so a lot of times pathology has edema in places it shouldn't be, or hypercellularity, or other things that are going on, other pathologic processes. So the T2s usually are combined with fat saturation to really highlight the areas of edema. But like, this is a T2 non-fat sat, and you still see the edemic lesions in the liver. So like diffusion is derived from a T2, other characterization sequences are derived from T2. So that's kind of how I split out the two things. So a lot of times when I am initially primarily reading, I fuse to the T1 to see where things are. And then if I find a lesion and I want to like go further characterize it, then I go into the depths of the various T2 derived sequences or diffusion or other things like that. Contrast is better seen on T1. So that's where we do use T1 for lesion characterization with contrast, but just like CT, you use the contrast, which is different from the sequence itself. So what sequences are we using? So for our whole body, we're doing T1 lavas pre and post, depending upon the sequence type or the protocol, but most of them are going to have a T1 post. We're also doing T2 single shots. We're actually experimenting with using diffusion images for the whole body instead of the T2s because they often show very similar information, and the diffusion gives slightly better target to background as opposed to the T2s. So these are what we use for the whole body. This is what they look like. And then, we fuse these with these guys, and that's how our whole bodies work. For our liver focused or any region focused exams, we use the same diagnostic sequences. So, high res T2s, TSC T2s, diffusion. For our livers, we're getting MRCPs. So we're getting the full MR experience for these patients. It's not like we're leaving anything out. All right, so our workflow. First thing that happens is, this is now out of date as of today, but we have in our EMR, we have multiple order sets, which are define the combinations that people need to place when they want to get these exams. All of our exams are read in concert with radiology. So there's an MR report for the region, as well as a PET report for everything that is PET related. These are all ordered together as one order set so that they're scheduled together, and that the separate accessions and separate reports are created at the same time. So we direct people, okay, you want a PETMR of the liver, fine, place the PETMR order set, then it will place the options. Okay, we want a PETMR whole body, great. And then this is the PET accession, and then we want to know, do you want a regular MR abdomen with contrast, or do you want one with EVIST, for example? So they pick the options that they want, those get signed, they send off to the scheduler. The schedulers then, run the orders through pre-cert, make sure that insurance is going to pay for it. Then the patient gets scheduled. Usually the scheduler then emails me or somebody else and says, how do we want to do this exam? What protocol do you want? We tell them the protocol. Then the MR techs do their standard MR safety assessment, which again is slightly different from PET, where they have to make sure there's no implanted devices, that the patient can fit in the machine. It's a 60 centimeter diameter, which is smaller than most MRs now. Most MRs are around 70. They screen for claustrophobia. They screen for the ability to lie flat on their back for 45 to 60 minutes. They screen for pain and anything else weird like that. Sometimes the patients are really big, and so we will actually fit test them. So we'll have the patient come in and see if they'll fit in the machine. We've rarely had patients that come that are too big, and sometimes we can switch them to PET-CT the same day. Sometimes we just have to say, I'm sorry, we can't do it. Then once all of this is done, the patient gets scanned. As we said, we have 2 PET accessions. We have the PET accession and the MR accession. The whole body MR images go to our PET accession. So that's the whole body T1 pre-post and T2 or diffusion. And then the focused region MR images go to the MR accession. And then those each route to the appropriate division work list. So nuclear medicine dictates the PET, and whatever division, neuro or abdominal or MSK or whoever dictates the MR accession. So all of these then get read in their divisions, and then we have a little mini divisional conference either by Zoom or in person where we talk about the findings and make sure we agree. So viewing the scans. MIM has no good default PETMR workflow yet. I've worked with them a bit. It's kind of a very slow iterative process. So in the meantime, I wrote my own. So this is just, mine is literally just a variant of the PET-CT one that we use at our site. It just is generalized so that it doesn't only allow 3 sequences. So you select the images that you'd want. So for a whole body, you're going to want the pre and post T1s. These are these auto bind things right here. And then you're going to want the PET and a non-attenuation corrected PET. And then I also have that whole body T2, which is down here at the bottom. So these 3 get selected, they get run into the workflow. It assigns where they belong. And then this is a bug that that MIM has yet to fix, but you have to select the PET image that you want, which is fine. You just do it, and then the images come up. So the really nice thing about this is you're able to flip between the MR sequences. This is where it's very helpful. So everything's co-registered, everything's fused, and then if you're like on the T1 post and you're like, is this enhancing? Then you can flip to the T1 pre and actually see without having the images move and slide out of the place. Similarly, you can then flip to the T2 and it's actually very, very nice once that's all working. The region of interest PETMRs, it's the same concept. You just select all the MR images that you need, plus the PET that you want to look at and the non-attenuation corrected PET, and then use that same workflow I wrote, which is generalized, and we'll just fuse everything and line them all up. And then you're able to flip between the 2. And we'll actually hopefully have time to show a demo of that. So our reporting, so all of our reports are loaded into PowerScribe 360 at a site level. They're standardized. They all roughly are the same stuff. And so again, we're dictating the PET and any areas that are not in the focused MR. And then the respective image does the MR. We either do it by Teams, Zoom, in person, kind of whatever it works. This is what our reports look like. I actually have gotten to the point of putting in CPTs because our coders still don't know what to do with PETMR. So we are building these as PET only with the diagnostic MR code. So the other side builds the MR code, we build a PET only. So do a little diversion into some interesting cases here, and then we'll pull up the slide demos. So this is our actually very first PYL patient that we did on the PETMR. And the main things that I like to point out is how good the PET is in the machine, even ignoring the MR. It's extremely high quality PET. And then on top of that, how much easier it is to interpret things when you have the MR to figure it out. So, this one, like there are 3 Mets on this image, right? So here, here, and here, but we also have the ureter here. So it would be very easy if you did not have the super, super high quality MR images to go with this to say, oh, that's ureter because it's so small, right? And if you even on chronals, you're like, is that ureter? It's sort of in the area, but some people would call it, some people wouldn't. But we have a presacral node, right node, left node, and this is ureter here. And you can see things that get quite close to ureter and you're still able to distinguish them. So because the machine is able to distinguish and you're not having kind of this blur of PET counts, making it difficult to tell things apart. So your lesion resolution is very, very high. We're routinely seeing prostate cancer lesions in 3 millimeter lymph nodes. So it's the whole notion that something has to be 8 millimeters, 10 millimeters to see it on PET is rapidly changing. This is that same patient. He also had a bone lesion in the lumbar spine. So we're able to see lesions everywhere. We're also able to, because you have the diagnostic images in the post contrast, you have definite confidence that something is a ganglia versus something is a retroperitoneal node. Here's an Axelman patient who's had multiple interventions to the prostate. They had, I think, originally external beam, followed by brachytherapy boost, followed by cryoablation or HIFU. I don't even remember exactly, but the PSA was persistently rising. So this is PET. So we can see that there's something going on right here near the vesicourethral anastomosis. And then on the diffusion, or actually, no, it's just the inferior portion of the prostate. Well, it's either at the anastomosis or the prostate, either case. You can see that there's some diffusion signal abnormalities here. You can see that there's kind of this evil T2 gray with soft tissue thickening, and then perfect fusion. And then you actually notice that this is fusing both superiorly and inferiorly. So this is actually probably on the margin of the cryotherapy ball. Post-contrast enhancement here as well, and then nicely fused. Similarly, this is the same patient, just, this is now the superior aspect, this is the inferior aspect, and you can see that really the sagittal helps a lot, where you can fuse it to the sagittal MR and really definitely give a diagnostic confidence that, hey, this is peripheral recurrence all around here. You guys, this is where you need to target. This is another area of response assessment where this is a patient who had cholangiocarcinoma and got lobar Y90. So this lesion up here is dead, right? Very little, almost no internal enhancement, some mild peripheral enhancement, very minimal peripheral uptake, photopenia and centrally. Non-viable tumor. That's great. Now, how we have here, another tumor. This one has kind of thick peripheral nodular uptake. It has thick peripheral nodular enhancement. They actually fuse very nicely. So this is recurrent such viable tumor, incompletely treated. And then also we had new disease. And these were very hard to see on the MR. In fact, they were missed by the abdominal reader when we first read out the scan. And so you can see here that, very, very tiny lesion on the PET. And if you really look for it, there it is on the MR. So we are also able to see new tumors on these patients that may have been missed or written off as noise, especially if they're getting conventional follow-up. So if they just had an MR, this probably would have been missed. Similarly, we can also look at lesions that traditionally PET has not been good at. So we're doing more and more pancreatic patients. So on the MIP, you can see that there's liver disease, not a question. This was actually, is there any disease other than in the liver that we need to pause on prior to doing locally directed therapy? And so this patient had a Whipple, and this lesion right here was right at the pancreatico-jejunal anastomosis and was an unknown, unexpected site of disease, which actually changes patient's therapy from local liver to just more chemo. So that was also not suspected on prior MRs or CTs. And then this is a patient that I had shown you the whole body earlier on about the super PET. So she had the pancreatic tail neuroendocrine tumor. They wanted to know, is there any disease outside the liver? And there are a couple things. So on the 3.5 minute, I would have said nothing really around here. But on the 20 minute, you can see there's increasing uptake right here. And what the story was with this patient is she had a distal pancreatic tail lesion, which required a large resection, and they actually had to resect portions of the colon. And so that this is actually along one of the colon resection margins. So there is residual disease there. This is also that pancreatic resection margin here, where the longer you acquire, the more you find. This lesion suddenly pops up. These lesions become more conspicuous, and this one I would have missed if I'd only had the 3.5 minute. The other thing that you can do with PETMR is you can acquire actually these dual time point delayed PETs just because the MRs take so long. So if you do a focused region PET first, which is around 30 minutes, particularly of the pelvis. So if you incubate the patient for 60 minutes, then to do a 30-minute scan, that's a 90 minutes. Then you start doing your whole body. And if you do your whole body in a way so that your head is the first thing that you start acquiring and then get down to the pelvis at the bottom, you can then get anywhere from 90 to 110 minutes after injection. And so on this patient, for example, she'd had a vaginal cancer, I think it's vaginal squamous cell, treated with surgery and radiation therapy, as well as brachytherapy. And they were like, well, is this recurrent disease? Is this post-radiation change? Is this real? Is this not? And you can see that on the initial time point, it says 5.4 SUVs. on the delayed time point, it's actually increased 50%. So this one I ended up reading as residual disease as opposed to inflammatory change. And so that's the end of my slides. And so while I switch computers here, so I can pull up the MIM. So 1 second. All right, so I have a couple patients here that are anonymized for IASNM. This is our MIM, this is our live MIM. So this first patient is one of our prostate cancer patients. So I will first, actually no, this is that dual time point vaginal cancer patient. So what we'll first do is this patient only had a T1 post whole body. So we're gonna pull up the whole body case first. So this is the PET-AC whole body. You can tell by the number of images, it's really large. Non-attenuation corrected, and then we'll do the whole body T2. So we'll use my PETMR whole body ST that I used. There is no pre, hit continue. And these are really large image sets. So that's one thing that I've constantly hoping MIM will continue to get better at, which is handling these large data sets. You need fairly strong computers with lots of RAM. So initially, most of our workstations only had 16 gigabytes of RAM. That's not enough. You can maybe load one PETMR. My workstation that I'm sitting at right now has 64 and it works a lot better. So first things it did is it loaded up the T1 post, the PET, the attenuation, the non-attenuation corrected PET and the fusion, right? So that's good. You know, that's like we're loading up a PET CT, but this is where it gets fun. So once I fix these little bugs here, now we're able, once I fix the size, okay. I have this little menu and I can switch between what I like to use predominantly, which is a T1 post, or if I need to further interrogate something on the T2, I can switch to T2. Everything's fused. A lot of times when you switch image stacks, it moves your position, which is really annoying when you're trying to read quickly. But because everything is fused preemptively, it doesn't do that. So that's actually very nice. So this is that same vaginal cancer patient. We can see here. This is this area of questionable uptake. I can throw an ROI on it. Is it real? Is it not real? So this one we're getting, this is the whole body, which was acquired later. It's 7.8 SUVs. So that's one thing. Then we can go back and load that patient as if it were the MR region. So here's the PET, non-attenuation corrected PET, diffusion, pelvic T2, diffusion ADC, coronal images, more diffusion, and then some sagittals. So those will load in the same way. Where's my axial T2? Big data sets, but still loads relatively quickly. Right. So the nice thing is when you're interpreting the MRs for the diagnostic rads or for anyone else that is dual certified, it's actually quite nice to see how well it fuses. You can then switch things around if you're interrogating a lesion without having to like re-find the lesion again on the next image sequence. You can, everything is pre-fused. So that's actually really nice. And it gives us a lot of, better interpretations, honestly. So this is that same region, right? So this one was acquired at 60 minutes post, 5.4, and our whole body post right here. 7.8. So that's where we kind of talk about like, oh, that's probably recurrent disease or residual disease as opposed to inflammatory change. And you can see that as you scroll through, it's fairly responsive. So MIM has a decent program, but I think the one thing that they need to work on is memory management, and hopefully we continue to work with them to get that fixed. All right, so some other patients that I've already preloaded here. This is one of our prostate cancer patients. So this is the whole body fused to the T1 post. This patient had incidental discovered prostate cancer on like a TERP. So we can see that there's PYL uptake all throughout the prostate, extending into the seminal vesicle. And then very tiny nodes. These were missed on conventional CT and nuclear, conventional CT completely missed. He has nothing on bone scan. So this was unexpected, moderate to high risk prostate cancer with metastases, another one here anteriorly. Just to give a sample of our image quality at the focused region. So this is our T1 post whole body high res. You can see it fuses very nicely to the prostate. Very helpful for our recurrent prostate patients who still have a prostate in. And then we can see, actually, there's another node here. And then some of these other nodes back here are very tiny, but still can be seen, and they have correlates on the MR. These would never be called by a diagnostic radiologist, ever. Never, 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 never. And then I think we had one more. Let's see. Sorry, my PACS is freaking out. And yes, this is our patient that I showed earlier with the cholangiocarcinoma Y90, right? So you can see the whole body decent, but it's really the power of the PETMR is shown off when you do the liver lesions. So let's throw in our livers. And this one won't take nearly as long, I promise. So sometimes this happens. This is where sometimes the patient breathes slightly differently, right? So one thing that you just deal with is you fix it. So you can see that the PET and the liver are slightly off. This is one of our earlier cases where we didn't have the patient breathing instructions to be exactly correct. So, but here we go. So this is that lesion I showed you guys earlier, completely dead up top, then incompletely treated right here, and then new was down here. Very hard to see on the MR, very, very obvious. It's right here. If you weren't looking for it, very obvious on the PET. So this is where these kind of, I think PETMR should be going towards, using the best of both areas rather than just swapping out the PET CT with an MR, because that is not nearly interesting enough. And so with that, I can pause and let you guys, we can start talking about questions.
Thank you very much, Shahein. Excellent talk, very clinically relevant. The first question is from Dr. Amna Hassan. She's a consultant nuclear medicine physician at Shaukat Khanum, Lahore. So she says, excellent talk, Dr. Tajmir. Couple of questions. How many patients do you schedule in a day, and how long the reconstruction takes?
Sure. So our scheduling is more limited by patient interest. We schedule for 1 hour blocks. So we could do probably up to 6 a day right now, just because of techs, when the techs work and what's realistically feasible to expect the patients to get to Emory, because our parking is complex and traffic and everything. So we could do probably 6 right now. I think the most we've done is 4. But you can schedule them in 1 hour. So it's really a 2-hour exam. So they come in, they get injected, to wait for 60 minutes and get on the table for 1 hour of imaging. Oftentimes it's a little bit less, but yeah, we could, all of my protocols, with the exception of maybe one, have less than 1 hour of scan time. And so if you block them for 1 hour of the actual scan and then 1 hour, whatever your uptake period is, you can fit them in. So that's how long we can do.
Thank you. We have another question from Justin Peacock. With PETMR, they have seen likely better results with diffusion weighted ADC. Have you thought about an abbreviated sequence for more rapid throughput together with T1 instead of contrast or T2?
So I have I'm experimenting with this because I really don't like T2 single shots. As a body trained person, I consider T2 single shots the tumor suppressing sequence, and I honestly find them kind of useless. And in fact, when I'm reading abdominal MR, I almost use them more as an anatomic sequence rather than a tissue characterization sequence, because I feel like you don't see the tumors very well. So what I've started switching is, on our prostates, I'm now doing whole body diffusion. I have a myeloma protocol that's very experimental and still kind of a hack because the machine software can't handle it. But we have managed to get the physicists and GE to get our whole body diffusion images to be very good, actually very, very good. And so now I've started doing the whole body diffusion instead of the T2, and it only adds maybe about 15 seconds of scan time relative to the PET acquisition, but it allows you to see quite a lot of things, and it decreases the extraneous stuff, right? So if you're using like a low and high p-value diffusion, if you see something on there, you interrogate it, and if it's not real, if it's like a node or something that's not having uptake, then you ignore it. But the goal for me is less rapid throughput and at the risk of compromising the exam. What I would rather do is have GE take the air recon coils and air recon software that they sell for their other MRs and put it in the PETMR. I've been harassing them for a year to do that. Air recons on average save around 30% of scan time. So if I can get my scans down to 30 minutes, it's even better. So I'm currently at like 42 minutes for my livers. 30% time savings there would get me pretty close to 30 minutes slide, which would help a lot. And then at that point, you're kind of limited based on how long your PETs are and how much image quality you want. So yeah, I think you can, with breast is challenging because the bore is smaller than your typical bore. So it's harder to get a patient prone and do the proper, full diagnostic MR with the patient in prone position. If it's possible if your patients are small, but it's very hard if they're not. I'm hoping that they can eventually make a bigger bore to make that a easier thing to do, because fitting the breast coil in there and everything is really challenging. I do think that diffusion and FDG often are complementary and show the same thing or very similar things from my experience. What I have found is that if you're using other tracers, the diffusion actually is very interesting, because then you are getting like a pseudo FDG surrogate at the same time. So with FDG, I find diffusion not as helpful. With non-FDG tracers, I agree, diffusion actually adds a lot. And then I had a question directly asked to me, am I getting reimbursed? And the answer is yes. I recently did an audit of all the exams that we've done. Maybe it was in July, and there's always like a 60 to 90 day lag. So it was basically through either April or May. And we are getting paid. CMS pays if you bill it as a PET only and an MR. Private payers are paying. What we have found is that sometimes the payers will underpay what you're supposed to get. And if your billing people are not on top of the ball, they may just accept that payment, and then you're suddenly losing a lot of money. So that's one thing that's going to be like an education piece as we continue to get a new EMR and a new billing system. But we are definitely getting paid from both private payers as well as CMS. We even got paid by Medicaid, much to my surprise. So it is viable from an economic perspective if you're doing a diagnostic MR and a PET at the same time. If you're doing only PETs, I don't think the machine economically is worth it because of how expensive it is. And your institution is probably going to be better off just buying a really, really high-end PET CT. But if you're able to get both, bill both, have your times work out, I actually think it's actually pretty decent. Not amazing, but it's decent, and it's not losing money.
Dr. Tajmir, thank you very much. This is Mark here in Central PA. Very much appreciate your talk. Nicely put together. I cannot tell you enough. It's a great quality presentation. Now, I did pose that question. I expected the answer that you have provided. Indeed, you would get paid because the images and the submitted paperwork is for two separate exams. So right now, there aren't that many PET-MR machines out there. So the reimbursement, the third parties that reimburse us for our work, thus far probably gonna be watching. But what I think we have to look forward to might not be quite as encouraging. And that is, well, let me pose it as a question. When was the last time that either you yourself or anyone else in this audience has received a payment for the right ventricular ejection fraction as part of a nuclear medicine study? Dr. Tajmir?
I honestly don't know. I've done a few of them, but I have not specifically checked for if those ever got paid.
Yeah, I think you'll be disappointed they haven't. And here is the history of it that predicts, you know what they say, right? History not necessarily repeats itself, but it certainly resembles itself a lot of times. What I mean by that is in the quote unquote good old days, we used to do first pass either with injecting MAA for the VQ imaging, that is Q imaging, and get a first pass acquisition and produce a first pass right ventricular, not left, right ventricular, of course, ejection fraction. We did the same thing with good old MUGA or radionuclide ventriculography, and also billed for both. And there was a reimbursement for both. Until, of course, the reimbursement entities such as Medicare and private payers figured out that, hey, listen, they're just doing one study. We're paying them for two separate exams, right ventricular ejection, left. And so they combined the charges. And of course, you see it across the imaging diagnostic field. They now combine more and more and provide reimbursement for less and less. So I think it might be, and this is just a acknowledgement, I think, of what the history ought to teach us. They're going to start combining, and you're going to be doing quite a lot more and getting the same payment or potentially less. It does not mean that we need to stop developing. Absolutely not. I'm not suggesting that in any way, shape, or form, but maybe we should be more active in reimbursement politics, which unfortunately we either as a society, as a groups, totally aren't. We do some, but it's highly inadequate in protecting our patients' best interests, because if we don't get paid, obviously we ain't going to be doing it. You can only lose so much, and you cannot make up for the loss in doing more studies. It's just going to be greater loss. So it's just a little note. One question that was very pointed, and that is how long it takes to take a study, to do the study, et cetera, et cetera. But the component that was missing in that question is how long, A, does it take someone at your level, so you double boarded, you read MRs and you read PETs and PET-CTs, how long does it take you to complete reading of one of those patients that you've done for say PYL study? And number two, or B rather, sub-question B, how long do you think is it going to take a turnaround time to report, as you do now, nuclear medicine physician reading it on his or her own, and a radiologist reading on his or her own the MR portion, and then having to have that Zoom meeting? How long does it take to turn around one of those studies?
Yeah, so for the PET portion, I don't think it's any longer than a PET-CT. And actually, Dr. Takokar and Dr. Mosley here are good that they're on the call, because they read them as well, so they can give their experience. I think from a time perspective, it's the similar. These are usually higher complexity patients. So take your high complexity PET-CT, it's a similar amount of time. It's not like a 10-minute PET. It's going to be probably closer to 30 minutes to read one of these, because you got priors and you've got to like look in the records and all of that kind of stuff. So there is more time, but I don't think it's any longer than an equivalent PET-CT for that patient would be. For the MR portion, when I read the MRs, I would then not be on nukes that day. They're the same as if I were reading an MR for that region. So it just depends on what kind of MR it is. The longest exams I have are the myeloma exams, which again are my experimental protocols. And part of the reason they take so damn long is because you have to look at every bone. Those take a long time to read. Yeah. But for Dr. Mosley or Dr. Takokar, I'd love to hear what you guys think about. Is it longer than a typical exam, or how much pain is it?
So before they address that question, if I just might put a little wrinkle on that nicely ironed answer, and that is, yes, I understand it takes you, but if you, for example, take that PYL case that you showed with the quote unquote presacral lesion, right? What I wonder is, because it has to go through two channels, right? One will be Dr. Tatalkar maybe, and the other one will be Dr. MR. So they will have to fuse their readings, right? Aren't they going to have some handshake on this report? So that part is an additional part, I would say, at least currently, until everyone is trained like you are. And even then, you think it takes you just as long to read the one that you were trying to display, with us here on a presentation forum, as it would take you to go through this PET-CT of the same patient?
I think for the MRs, when I read a PETMR and I'm doing the PET portion, I think I'm a little bit faster, because I have less, at least for me, I hedge less, and I'm staring at the attenuation correction less. So a lot of times when I'm looking at attenuation correction only CT, I'm trying to guess where the uptick is. And sometimes I'm like, is it here? Is it there? And I like go back and correlate to other things. When I'm looking at the PETMR, I actually I have contrast. I know where the ureters are. I know where things are. It's much easier for me to tell where things are. And so I'm more confident and I'm faster. So there are some areas where it's more complex. So it takes longer for me to pull up the priors. It takes longer for me to look at the records. But other areas where if it's like a brand new first PSMA patient with incidental prostate cancer found on whatever, like that patient, it's actually very fast because I'm like, these are nodes. I don't have to equivocate on if it's ganglia or not, because you can see on the MR it's a node. I go back to the and I don't have to worry about if it's ureter because I can see the ureter. So there's areas where improved image quality makes your PET faster because you are hedging less. Now maybe if people are more of a hedgy reader and say, well, there's uptake in the left pelvic sidewall, it could be ureter, could be node, could be ganglia. Well, of course it's going to take longer. But if you're going to make a report that says it's there and that's it, I think it's actually, for that particular purpose, it's faster. I think there is intrinsic patient complexity based on the patients who tend to come to PETMR, but for our more simplistic, initial diagnosis prostate cancer patients, it's actually not that much longer. And our readouts, our combined readouts are fairly quick. It's okay, I call up abdominal, hey, where did you see the lesions? Okay, yeah, it's here. And then we usually pull up in Zoom. And then for the, things that they miss, because often they're really tiny nodes, they'll say, okay, where did you see Mets? Because now it's got to the point where they know that they're going to miss nodes. And I just pull diffusions and say, these guys all have uptake. And then they say, okay, we'll mention that they're below size threshold, but they're there. Usually it takes longer to find a time to meet with them rather than it does to actually go
Exactly.
over.
And that was one point I was just about to say, but you pointed it out very kindly that I have a very hard time just finding people to talk to because they're doing also something, I'm doing also something, and then finding the common time that we maybe aren't doing something else to talk and go over this. But be it as it may, it will take a while before we have enough of you out there to read. So I'm hoping that will go faster than I anticipate. But maybe we can learn in the meantime to clone you. And I'll have the first clone of you in my clinical shop. So I just want to put my order in early. The first clone of you is mine. Okay, with that being said, if I may just project, and then I'll leave you alone all.
Can I but then just wanted to let you know that there are, early adopters always have to pay the fine, right? So we are kind of the early adopters of.
Sorry to interrupt you. Your voice is muffled.
Voice is muffled. Maybe later on then.
Okay, while you're putting your voice together, I just want to point out one last thing and then I'll step aside because there's, I'm sure, many other people who want to ask you a question. So this is just from an article that I randomly pulled off while you were presenting. And that's an earlier 2018 article that points out several ganglia that are commonly providing some of the false positives. Going back to your presentation, the first PYL case that you've presented had the presacral lesion. How did you know it was not presacral ganglia? Because that's exactly what it looked like to me from afar over this presentation.
Because it's in the wrong place. I mean, that's the easiest answer.
Right,
it's not near the neural foramen.
Please look at this image. You think it was that different?
Yeah, it was further down posterior, Dr. Tulczewski.
But the ganglia go down posterior. There is a rundown of ganglia. That would not be an easy answer. I mean, I understand hoping to have an easy one, but it isn't. Presacral, more likely we would see usually presacral mets with, say, colorectal. Now, we also felt, I think in the earlier days, that presacral would be very common with prostate, and they are sometimes, but then those ganglia really throw in a monkey wrench in our smoothly spinning wheel, because I don't think we're that great at differentiating false positives from true positives. And oftentimes, of course, the therapy will be external beam, and you will never know that is, and you can't biopsy. It's too small to biopsy, too deep, too small. So you kind of caught between the rock and the hard place a little bit. So with that, I'll step back, and I do appreciate your lecture. I think it's an amazing technology, and I really thank you for putting it together so just super professionally. Thank you.
Thank you, Dr. Tuljiski. I have a couple of questions in the chat box here. One of them is from Chitra Saxena, and she's asking how many peer-to-peer reviews you have to do while people order PETMR on the average, or what percentage?
To be perfectly honest, we don't do them at all. It's the referrings that has to do them. So that I am limited in the amount that I hear about them. But on the flip side, I actually do not hear as many complaints about them, because a lot of, at least our initial branding and marketing for this has been patients that you would normally be getting a PET and MR for. It would be the ideal candidates for this. And so I think those patients are kind of in a pathway where their insurance is okay with this, where they're going to get a PET, they're going to get an MR. The pre-certs are actually done separately because it's technically separately to exams. I have seen a few cases. We've run into a few where for PYL, the payers are refusing for upfront staging because they're still using AIM, which is one of the radiology benefit management guidelines, which says to not use PYL for upfront staging, but I think that will change eventually. But I've not heard much complaints about people not getting approved except for PYL. And I think that's more to do with PYL than it is for PETMR. There was a Dr. Halkar question. Yes, we do have, the question is protocols are tracer specific and organ specific. That is correct. They're more, the way I would think of them more is you have the tracer protocols, and then you have the diagnosis or region specific protocols. So if there was an adenoid cystic, of our head and neck protocols, there are 5. We do have one that's an MR face perineural type spread tumor protocol, which would be one of the ones that they do, and it just changes the MRs that they do during the head and neck acquisition. So yes, we do have kind of disease specific protocols. That's generally how MR is protocoled, is by disease specific or like clustered anatomy / disease specific. Justin Peacock asked, is there a reason why nuclear radiologists couldn't read both? We can. I read the myelomas myself because I did have an MSK collaborator, and then that person left Emory, so there is no one else. We have a couple other dual boarded people, and occasionally one of them will be on the abdominal side with us. So there's no technical reason. It just helps to have the workflow established where one person reads one person reads the other. You have 2 separate eyes, and then you're going to a conference, and by using multiple people, and even up to and including trainees, it helps you not miss things.
Excellent. Thank you so much, Shahein. A very nice discussion among the audience. And I would like to thank everyone who joined in for this webinar. And is there one new message? I think, yeah, it's just thank you for your presentation, and enjoy rest of your day. We'll see you next time, next month. Take care. Thank you. Bye.
Thank you.
Thanks a lot. Bye.